Good afternoon and welcome to this afternoon session on thyroid cancer. I hope you all enjoyed the warm weather and the delicious lunch today. We're ready to start for a very interesting session, and Dr. Filetti is with me. I'm Giuseppe Barbesino from Boston, and we're delighted to invite Dr. Miyauchi from Kuma University speaking about active surveillance. Dr. Miyauchi.
Thank you very much. Well, I have nothing to disclose. Well, during the recent 3 decades, the incidences of thyroid cancer increased rapidly in many well-developed countries. The increase was mostly due to increase in detection of small papillary thyroid cancer. Papillary thyroid microcancer 1 centimeter or smaller became about 50% of the thyroid cancer cases in many recent series. However, mortality from thyroid cancer remained stable. With these data, many researchers suggested overdiagnosis and overtreatment of small papillary thyroid cancer. Regarding papillary thyroid cancer, many autopsy studies on subjects who died of non-thyroid diseases reported high incidences of latent thyroid cancer. If we look at the incidence of latent thyroid cancer, 3 millimeter or larger, which can be detected with ultrasound examination, 2.3 to 6.4% incidences are reported. Dr. Takebe in Japan conducted a screening study for thyroid cancer using ultrasound and fine needle aspiration on subjects who visited his center for breast cancer screening purposes. And he found that 3.5% of Japanese adult women having small thyroid cancer. 3.5%. This incidence is consistent with the incidence of latent thyroid cancer and more than 1,000 times the prevalence of clinical thyroid cancer being reported in Japanese women at that time. With these data, I got the hypothesis that most papillary microcancers would remain small. However, some of papillary microcancers will grow. Of course, any advanced thyroid cancer was a small cancer at its origin. The issue is how can we identify the minority that progress? I thought observation without immediate surgery will give the answer. And doing surgery only for those that showed slight progression would not be too late. Immediate surgery for all papillary microcancers might result in more harm than good. With these considerations, in 1993, 26 years ago, I proposed an observation without immediate surgery clinical trial at the doctor's meeting of Kuma Hospital, which was approved, and the trial started in the same year. This trial later became being called active surveillance. We made diagnosis with ultrasound-guided fine needle aspiration, which is very accurate. For high-risk papillary microcancers, we recommended surgery, and for low-risk papillary microcancers, we proposed observation and surgery, and patients chose one of them. We followed patients who chose observation with ultrasound 6 months later and once a year thereafter. We recommended surgery if the tumor showed increase in size by 3 millimeter or more, or if novel lymph node metastasis appeared. High-risk papillary microcancer was defined as having one or more of the followings: lymph node metastasis or distant metastasis, which is very rare, extrathyroid extension, high-grade cytology, which is also rare for microcancer. We cautiously included tumors located near the recurrent laryngeal nerve or attaching the trachea in high-risk category. Low-risk papillary microcancer was defined as having none of the above features. We did not exclude patients with family history for papillary thyroid cancer or patients with multiple foci. 5 years ago, we reported the outcome of our clinical trial on 1,235 patients. Please note, 5% of the patients had family history of papillary thyroid cancer, and 12% of the patients had multiple foci. During active surveillance at 10 years, 8% of the patients showed tumor enlargement by 3 millimeters or more. And at 10 years, 3.8% of the patients showed lymph node metastasis. If we look at the age at the presentation, the patients younger than 40 years tended to show tumor enlargement, while patients older than 60 years were less likely to show tumor enlargement. Middle-aged group were between these. Multivariate analysis for tumor enlargement revealed only young age was the significant factor, and family history and multiple foci were not. Regarding the appearance of lymph node metastasis, again, patients younger than 40 years tended to show lymph node metastasis, while middle-aged and elderly patients were less likely to show lymph node metastasis. Multivariate analysis for appearance of lymph node metastasis revealed that only young age was the significant factor, and again, family history and multiple foci were not. During this 8-year period, 2,153 patients with low-risk papillary microcancer were seen at the Tumor Hospital. 55% of the patients chose observation, and 45% of the patients underwent immediate surgery. After surgery, 5 patients had local recurrence, which was successfully treated. After surgery, 5 patients died of other diseases. So these patients were alive without evidence of disease. Among the observation group, 94 patients had conversion surgery for various reasons, including change in patient's mind. After surgery, 1 patient had local recurrence, which was successfully treated. During the active surveillance, 3 patients died of other diseases. Very importantly, more than 1,000 patients were alive without disease progression. Therefore, these two treatment modalities were oncologically excellent. Please remember this figure. This figure will appear again for cost analysis later. However, when we looked at the incidences of unfavorable events such as temporary vocal cord paralysis, permanent vocal cord paralysis, temporary and permanent hypoparathyroidism, and patients on levothyroxine, and patients with surgical scar, these instances are significantly higher in immediate surgery group than active surveillance group. I want to tell you that all of these surgeries were done at Tumor Hospital by well-experienced endocrine surgeons. This is the reality. This patient, this woman with papillary microcancer, which was detected a screening study, underwent right hemithyroidectomy with central lymph node dissection in other hospital, not Tumor Hospital. Very unfortunately, this patient acquired bilateral vocal cord paralysis immediately after surgery, requiring tracheostomy. This kind of tragedy never occurred in patients during active surveillance. Yeah, that is true, very important. Well, Carrie Lubitz warned that the estimated overall societal cost of well-differentiated thyroid cancer care in the United States in 2013 might exceed more than double in 2030 based on the current trend in the incidence of well-differentiated thyroid cancer. Of course, medical cost is a very important issue for the society and also for individual patients. Therefore, we calculated the cost of active surveillance and immediate surgery for 10-year period management. based on our actual flow of the patients. So the cost included cost for conversion surgery or cost for the local recurrence disease. And we found that the total cost for immediate surgery for 10-year post-operative care was 4.1 times the total cost of active surveillance for 10-year period. So, in summary, oncological outcomes of the immediate surgery and active surveillance was similarly excellent. However, the incidences of unfavorable events were definitely higher in immediate surgery group than in active surveillance group. In addition, medical cost of immediate surgery was 4.1 times the cost of active surveillance. Therefore, active surveillance is much better than immediate surgery for the patients with low-risk papillary cancer and also for the society. Currently, at Tumor Hospital, we recommend active surveillance as the first-line management for the patients. Cancer Institute Hospital in Tokyo conducted active surveillance 2 years later than Tumor Hospital. Their outcome was basically quite similar to our outcomes. Taking the outcomes of these two Japanese trials, 2015 ATA guidelines now accepted active surveillance as a management for alternative to immediate surgery in selected patients. Japan Association of Endocrine Surgery published guidelines in 2010, and that accepted observation for low-risk papillary cancer. This guideline became the first guideline that accepted observation. The guideline was revised last year, and the guideline now actively recommend active surveillance. Well, patient's point of view or emotional issue is also very important. Louis Davis visited Tumor Hospital and conducted a questionnaire survey for patients with low-risk papillary cancer on active surveillance at Tumor Hospital. During a 3-month period, she was able to enroll consecutive 249 patients on active surveillance. Reply rate was very high, and 37% of the patients replied that they had cancer worries sometimes. However, 60% of the patients replied that the worry decreased over time. Very importantly, 83% of the patients replied that choosing active surveillance was the best decision for them personally. So they were satisfied with active surveillance. Well, one might argue that active surveillance is merely delaying surgery. However, we showed that progression rate was significantly lower in older patients than in younger patients. After 10 years of active surveillance, all patients get 10 years older. Therefore, risk of progression, that is true, 10 years after surgery, an observation, all patients get 10 years older. The risk of progression would decrease over time. So we estimated the lifetime probabilities of disease progression. First, we calculated disease progression rate at 10 years of active surveillance in patients in their 20s to their 70s. You can see young patients had a high rate of disease progression rate. However, the rate significantly decreased with age. We had 3 hypotheses. Hypothesis A, papillary cancers progress according to the age-decade specific progression rate over the patient's lifetime. Hypothesis B, the patients who showed disease progression during the initial 10-year period undergo surgery. The remaining patients have only tumors that do not progress in the succeeding period. Hypothesis C, hypothesis B may be possible, at least for some patients, but applying it to all of the remaining patients might be too optimistic. The actual probability might be between A and B. Well, the estimated lifetime probability comes like this. We think red line is the most likely estimate. You might think 48.9% of lifetime probability of disease progression in patients in their 20s, and 25.7% in patients in their 30s are too high to accept active surveillance. However, these figures indicate more than 50% of the patients in their 20s at presentation, and about 75% of the patients in their 30s will not require surgery for their lifetime. And older patients are less likely requiring surgery for their lifetime. Well, you know, the doubling time is a validated way to analyze and express tumor volume kinetics over time. However, it has two major limitations. There are 5 sets of sample data showing rapid growth, moderate growth, slow growth, decrease, more decrease over time. Please note, vertical axis is shown in log scale. The doubling time comes like this. If the tumor shows decrease of tumor volume over time, these cases, doubling time for these cases are given in negative values. So this creates discontinuity problems, A, B, C, D, E, no connection. And the magnitude of a doubling time value is opposite of magnitude of growth rate. If we calculate inverse of doubling time, these limitations seems to be resolved. I propose calling this value doubling rate, since this value indicates the number of doublings that occur per unit time. Negative values indicates number of halvings that occur per unit time. With the use of the doubling rate, we were able to show tumor volume kinetics during active surveillance. Positive values indicate tumor growth, and large value indicate rapid growth. Negative values indicate decrease in tumor volume and or regression of tumor. So open column indicates patients who retained active surveillance, and solid columns indicates patients who had conversion surgery due to tumor enlargement or appearance of lymph node metastasis or for other reasons. During active surveillance, only 3% of the patient tumors showed rather rapid growth, having the doubling rate 0.50 per year or larger. And 22% of the tumors showed slow growth, and 57% of the patient tumors showed stable disease, and very interestingly, 17% of the tumors showed decrease in their tumor volume over time. So, regarding the natural history of papillary microcancer, the tumors showed rather rapid growth, the slow growth, the stable and shrinkage were 3%, 22%, 57%, and 17% respectively. Deceleration and regression of growth rate are common phenomena in the natural history of papillary microcancers. In order to implement active surveillance, of course, informed decisions by patients are very important. However, this is strongly influenced by who inform and how inform. I think physicians should be confident on the information. I think education for physicians, surgeons, patients, and general public are necessary. We need good sonographers, and we also need follow-up system. At Tumor Hospital, we have a recall system for non-show patients. Finally, I want to give you a simple knack to help patients in making their decisions. It is very simple. Giving a brochure, performing pioneer aspiration. This is a brochure explaining about the active popular microcancer given at Tumor Hospital. Giving this kind of brochure after pioneer aspiration results is not good. Before pioneer aspiration. That is the trick. Well, 17th Congress of Asian Association Endocrine Surgeons is going to be held in March next year in Melbourne under the Congress President, Julie Miller. Please join us. Thank you very much.